Okay, our next presentation is Child Fatality and Near Fatality External Review Panel, the 2023 Annual Report, Findings and Recommendations. Everyone does have the agenda, so they have the description. But I did want to introduce Joe Griffith. He's been around Case-Ben for a long time, and Alicia Mahoney from Justice Cabinet. Both of them have worked with us diligently on the Child Home Safety Committee. And with that, we'll turn it over to your all's presentation. Thank you.
Sure. Okay, say it again, I'm Joel Griffith. I've worked in child welfare, child protective services, retired from DCBS, worked for Prevent Child in Kentucky. I worked with the panel as a panel member for several years. Then I took a position with the Justice Cabinet, and I'm a case analyst, meaning I read cases, do summaries, present those to the panel, and help with writing a report and some data collection and stuff. So that's my role.
And I'm Alicia Mahoney. I've been with the Justice Cabinet for 15 years now. I've been providing technical assistance to the panel for over 7. Joel's our expert. He's gonna, like he said, he reviews all the cases and really does a great breakdown for the panel. So we're gonna refer to it as the panel throughout the presentation. It was created in 2014 by statute. It is a panel of experts. This is not a citizens review panel. So there are 22 members. These are unpaid volunteers. So we think that's important to note. They're not lobbyists. They conduct a comprehensive retrospective review of all child fatalities and near fatalities suspected of abuse or neglect. And by statute, the panel is supposed to meet quarterly.
You're done.
Oh, am I too far away?
You can use that.
Okay. By statute, the panel meets quarterly, but since 2021, we've been meeting monthly in order to review all of our cases.
Can you share your screen so we can see the presentation virtually?
There we go.
Thank you.
Yeah, all right. Oh. So as we said, the panel reviews cases from the Department of Community-Based Services and the Department for Public Health. It's important to note that DCBS conducts their own investigation into the fatality or near fatality, and they determine whether or not to substantiate abuse or neglect. The panel then conducts a retrospective review of these cases regardless of the DCBS finding. So cases reviewed from the Department of Public Health are those referred from the local child fatality review teams. These cases were either not screened in or not accepted for investigation. So in 2023, we reviewed 202 cases. These comprised of 68 fatalities and 134 near fatalities. So as part of the review, the panel will they'll do in-depth discussions during their meetings. During this, they will identify a category, what are the family characteristics or risk factors, and then they will determine what the outcome was. So through a systemic lens, the panel promotes accountability while avoiding blame of individuals and agencies. So as part of Senate Bill 97, we now have to do a recommendation to a specific agency. That agency has 90 days in order to respond to us of whether or not they're going to implement our recommendations. They must tell us why they're going to implement it, and if not, why not?
Can I add something?
Yes.
So that was a huge win for us because for those who have been in government and you write reports and recommendations are made and sometimes they just sit there.
Yeah.
And so this really made a big difference, at least for the panel members and I think for us, because it allowed us to see action being taken, and if not why, then we could come back and say, okay, this is what the committee or this is what the responding agency said. They said they can't do it, so then we think, okay, how do we address this now?
There was another point we were going to add to this. So also, it's important to know too that we collect a lot of data. So we have 22 different screens in our data tool and over 220 data points. And those help drive our recommendations at the end of the year. So these are some of our main findings. As you can see, children under 4 are at the highest risk of maltreatment. This is consistent with national data, and we continue to advocate prevention efforts should be focused on this age group. Anything else on that one? So here's a few of our other key findings from last year's report. As we mentioned, the panel tracks family characteristics or also risk factors. This slide shows our top characteristics commonly found in the fatal or near fatal cases. It's important to note that we do not see the actual household income. So when we identify financial issues, this is based on a family that receives services. So if they have SNAP or WIC, they qualify under our definition of financial issues. Trying to think, is there another one we want to define, Joel?
Substance
Impaired,
abuse.
yeah, and impaired giver as well. Our definitions, we get to use our own discretion. We do not necessarily have to have a positive tox report. If there is any suspicion of impairment at the time, then we will say it's impaired caregiver. So for instance, if there's a documentation in the law enforcement record that says they suspected the parents were under the influence, yet they failed to do any type of tox report, we can say they were impaired. What do you want to say about substance abuse?
Just it's in the home or by the caregiver and also in the child, which
Yeah.
is pretty rare. But
Yeah, and all of our definitions, we have guidelines on how far back we go before we count them. So like with criminal history, it's 60 months. We exclude all traffic violations. DCBS is 60 months. Okay, so we're going to talk about some of our trends that we saw. Overdose ingestion has remained one of our top trends. As you can tell, there was a slight decrease last year. However, it still remains one of the top types of cases we review at the panel. And when we look at comparing KIPRIC data at the end of the year, we can really see that what we see is a very small subset compared to the overall number. And historically, the majority of overdose ingestion cases reviewed by the panel resulted in a near fatality. However, we have noticed a lot more fatalities in the recent years. And then the next slide will.
most of those are from fentanyl.
Correct, yes. So we do track the types of substances ingested. And I'll say too, we do not track it in synthetic, and now the way we track ours is based on what the Department of Public Health tracks so that we can compare data comparatively, and it's the way our system is built. So you'll see that the top 3 substances ingested this year were opioid, which includes fentanyl, buprenorphine and methadone, cannabis or THC containing products.
Just as a sign, naloxone, I was looking at these last night and I thought, naloxone, why is that on there? The reason, I'm thinking the reason it's on there is because we have a lot of kids who ingest Suboxone, and an ingredient of Suboxone is naloxone. So that's why that's on there. I thought, what? Because I've never read a case where a kid ingested someone's Narcan. But it's in the Suboxone.
Thanks for that clarification, because yeah, that doesn't make sense.
Yeah, and I think a lot of what we see in those types of cases is you see the kids doing what they see their parents do. So if a parent is taking a Suboxone strip, the kids just mimic what their parents do. We don't find that it's intentional. It's usually accidental, which is why we really push for preventative measures on safe storage. So this screen will show that we have seen a massive increase in cannabis or THC containing products that result in a near fatal or even fatal event. We have seen an increase in the fatalities with the cannabis and THC containing products. A similar trend can be seen when you compare the emergency room data. With the exception of one panel case, all cases in this chart are 4 years or younger.
One of the, I think it was this year, these all run together, but one of these years, we had a 3-year-old that ate 2 Delta-9 gummies and died.
Yeah,
Just 2 of them.
yeah.
I mean, we were pretty shocked by it, but, and then we looked in more research and it wasn't like the only case in the nation.
No,
It's really
and
dangerous.
died fairly quickly.
Yes.
So the American Academy of Pediatrics published a recent study demonstrating a consistent increase in pediatric edible cannabis exposures over the last 5 years with the potential for significant toxicity. So it's definitely becoming more of a problem. So as we said, we use our data to put together recommendations. Recommendations this year focused on overdose ingestion were mainly addressed to the Kentucky Board of Medical Licensure. We really wanted them to try to make a required 1-hour training to medication-assisted treatment providers. The education should focus on safe storage of the medication, educating their clients with infants on safe sleep. Even though the drugs are prescribed to you, don't sleep with your kid. There's still a risk. And then mandatory reporting duties. You'll hear us talk about this later on. There is a lot of issues with, especially at panel meetings, you'll hear doctors talk about they call it in and they can't get the case accepted. And a lot of that is, I think we need additional training for medical providers on what is the requirements needed by DCBS. I think that's it.
So we're going to switch gears here and take turns. So let me turn to my right tab.
While he's finding that, we also asked that there be a public service campaign targeting the distribution of THC containing products about safe storage. We really want those FDA warnings clearly visible to consumers so that they understand the dangers.
And I'm thinking in terms of THC, my fear is that this, if we don't get ahead of this, this is going to be an increasing thing because it is going to, well, it is technically legal, I don't keep track of it, but with prescription, states around us, it's much more accessible. And, you know, someday it may be here. And if we're not ahead of this in terms of safe storage, it could get much worse. I also wanted to mention when we're talking about recommendations, an outcome of the panel's work in the area of ingestion has been working with K-SPAN, setting up the safe committee. And I should also mention a big part of that was the medication lockbox distribution. We'll talk about this more later at lunchtime, but just we have received a lot of support from Kentucky ASAP. Thank you, Van. And we've distributed a whole lot of medication lockboxes. So we appreciate the partnership with KSAP and with K-SPAN. So we're going to talk now about substance-exposed infants and NAS children under the heading of Plan of Safe Care. So Plan of Safe Care is our primary recommendation around addressing the cases that we see. So the chart you're looking at now, the blue line is the total number of substance-exposed infants that we've seen on the panel. Obviously, that's a tiny sample of the whole number in the state. The orange line is the number of cases where the child was NAS, was diagnosed with neonatal abstinence syndrome. That number that's covered is 32. So you see a trend is going up over the last several years. Just some background information, there's 39 cases that we looked at this year that there's exposed prenatally. 19% of the total cases that the panel reviewed of near fatalities and fatalities involved substance-exposed infants. The victim being involved, 39 of the substance-exposed infants, so 12 were NAS babies. Just to put that in context, I think in the most recent year, the data has there was about 1,000 babies, 900 and some NAS babies in Kentucky just this year, or the year we're looking at, which is fiscal year 22. So, and you see that number has doubled over, and you see a similar increase over the last several years in the total number of NAS babies. So again, we try to compare the data we see, recognize that most of the cases we see are the worst outcome for these kids, but the total number impacted by these issues is much larger than what comes to the panel. So I need to define plan of safe care. It is a federal mandate that kind of falls under DCBS or the cabinet's responsibility, the way it's phrased right now. So it falls into that. The bottom line, it does not happen consistently in Kentucky, at least not on the panel cases. And I think from other data case sources we see, it doesn't happen. So what it involves is a plan of safe care is a collaborative effort where a team wraps around a family in which there's substance exposed infants, an NAS or substance exposed baby. So it doesn't have to be diagnosed NAS. It's any substance exposed, prenatally substance exposed baby, including fetal alcohol effects. So they wrap this team around them. The team addresses obviously the safety and welfare of the child. It addresses the caregiver in case mom or dad's not the caregiver temporarily. If it's grandma, it provides support to them. It should address the holistic needs of the substance abuse family. These are complex families. In addition to substance abuse families, you have those issues that go along with substance abuse, unemployment, housing issues, trauma history, dual diagnosed mental health issues. Van, you mentioned that. So those are all issues this team needs to wrap around and support the family in a way that's holistic and supportive and non-judgmental. That's the ideal. That's not what we see in the panel. That's not what we see based on other data in a lot of these cases.
Joel,
I'll just add one thing.
hovering around 1,000 cases a year, 12 being referred to the panel seems low. Can you explain to me what?
Well, we're just looking at those kids that die or nearly die.
Yeah, and just because they're diagnosed with NAS does not mean they would automatically get referred to us. There has to be a fatal or near fatal event.
Yes.
And then that's how we find that data. And I think in addition to what Joel said, when we say the plan of safe care falls with DCBS, this is not a fault of DCBS. This should not be
Yes.
under them. Now, if they accept a case for investigation and it goes down that pathway of plan of safe care, that's acceptable. But we think this needs to be something outside of DCBS, maybe with public health. We've asked for a higher level policy involvement because again, it needs to be a collaborative, holistic wraparound services.
And I'll give you a case example that we see, unfortunately, way too often. You see mom, she's pregnant, she gets into treatment, she gets on MAT, assisted treatment, great, it's clinically proven, it works. She gets involved in that, she has the baby, obviously it's gonna have Suboxone in her system, or actually Subutex in her system when the baby's born. So it will get referred to the NAS registry. It will get referred to DCBS. DCBS is not going to accept that report because mom's in treatment. She's got a plan. That baby's not at risk right at that moment. Baby goes home. No services unless she gets connected to somewhere else. There's not this wraparound plan. And then when you think about having a baby and all that stress, that's a really high risk time for
Well,
relapse.
that's what we were gonna say, yeah.
So that's kind of why we really think this is important. That I think goes to the point too that Alicia said, it is not a DCBS issue. This is a public health, mental health issue where DCBS needs to be a partner.
I don't know if we're gonna talk about Kentucky Moms Matter, but.
We are, but we
Okay.
can now.
I was just saying, I think that's a great program that provides the
Yes.
case management that's needed for these moms.
And that will fall under our recommendation. So this is just a chart of the type of medications you see. And I keep talking about the NAS registry. I should probably explain that. How many are familiar with the public health NAS registry? Okay, what it is hospitals have to report, don't have to, hospitals voluntarily report to the NAS registry. It's a DPH issue. They collect lots of great data on this. And so that's what I'm referring to when I talk about that. So the data that we see in terms of about 30% of the babies born will have more than 2 or more substances in their system. That's similar to what you see in the NAS registry. So it's not an anomaly that we see here. So here's the ones you see. It's fairly similar to the other ingestions. I think it was 53% of the panel cases, if you combine fentanyl, heroin, MAT, and opiates, that's 58 or 53% of the cases in the sample that we see. That's what kids are exposed to. And and 28% of the cases we looked at were lacking a good plan of safe care, and 39 of the substance-exposed infants, 18 and NAS babies, 18 of those cases were fatalities. So these babies are at high risk. The next slide, thank you. I can't do two things at once. This is the interesting slide from the registry, the Public Health NAS registry. So what we know, just looking at this quickly, is that the blue line are moms, are NAS moms, and the orange is non-AS moms. So it's no surprise that AS moms are later to get involved in this kind of, in prenatal care. And you see it just kind of reverses itself. It gets worse towards the end. Similarly, they look at, and I don't have a chart for this, but this is just the first appointment. They also look at this method where they count the first appointment and the number of visits. So it's a more qualitative piece. NAS moms perform more poorly in that measure as well. But there's a positive in this when I saw this data. And it's called trimesters, and I do not understand why there's 4 trimesters. It doesn't make sense to me, but this is about the first 2 months. And the first 2 months, 75% of these NAS moms are seeing a doctor within the first 2 months of their pregnancy. What a great opportunity to start services. So our message has been through the plan of safe care, and we'll talk a little more about that, is that we really need to get, before the baby is born, we need to get these services in place, because that's when you're going to prevent the long-term negative outcomes for babies. Just other kind of overall data, Kentucky is much higher than the national average in terms of NAS babies. And then if you in the NAS report, they have a chart by counties. It is really kind of astounding, the difference, like 4 and 5 times the rate in Eastern Kentucky than in Central Kentucky of NAS babies. It really hits home. So we had 2 primary recommendations. I will start with this one. What we're asking the public health DPH to do is improve the accuracy of the data in the NAS. This is not a criticism of them. They do a really good job trying to get this data, but I believe my understanding is that it's voluntary. So they're not getting it from all hospitals. So we would like DPH to do what they need to do in association with the Kentucky Hospital Association to improve that, because it's really important data. The other thing that we're recommending is that the governor's office convene a high-level group to develop a plan, an actionable plan to design a plan of safe care process. There's a lot of plans in that sentence, in Kentucky, one that works. We've been making this recommendation for plan of safe care improvement for 5 years.
5 years, yeah.
And this year, we convened a group of folks from the panel, other experts, and of course, DC panel staff, which is us too. Logan's here now, well, he's a new addition, so maybe he'll get drug into this as well. But we looked at other states, we looked at other practices, we attended a work group or a webinar from the National Center on Child Welfare and Substance Abuse. One of the things we saw was there's a lot of states that don't do much better than we do, but there's a lot of model states. And the model system, a few features of that is what I talked about, is that wraparound piece. It doesn't drop the whole process in the lap of DCBS. It can be done by OBGYNs, medical hands. Any number of people can take responsibility, and it's collaborative. So that's what we want to happen in Kentucky, and we've come to the conclusion that if it is not designed either through legislatively or administratively with that level of support, the system's probably not going to change. So that's kind of that recommendation. Did I get all that?
Yeah.
Okay, and then you mentioned the Mom Matters. This wasn't a recommendation, but when we pulled this group together, we kind of discovered an opportunity that when I mentioned DCBS sometimes screens out these NAS cases because they don't meet their investigation criteria. At this point, nothing happens. So what the group is working on doing, primarily DBHDID and DCBS, is creating a system when they get that screened out referral, they can automatically link it to Mom.
Yeah. All right, so next we're going to talk about our physical abuse cases. As you can see, this last year, we reviewed more cases of physical abuse than we ever have before. 78% of these cases resulted in a near fatality. What's even more concerning is 23% of these cases met the panel's definition for torture. And we do use the Knox definition, which is the American Pediatrics definition. So sadly, 70% of these cases reviewed were suspected to be caused by the child's biological parent. 47% of all the physical abuse cases had a family characteristic of domestic violence, and it is well established that children exposed to domestic violence are at a higher risk for child maltreatment. So some of our recommendations. So as you all may know, Kentucky has a multidisciplinary commission that meets on all child sex abuse cases. One of our recommendations, which we have made before, is that these MDT teams should be reviewing physical abuse cases that are fatal or near fatal. And the reason for this is to really help with the communication barriers. So you'll have CPS investigating, law enforcement investigating, and medical providers all involved. There can be a plethora of communication barriers when those three systems are trying to work together. MTD teams can alleviate that issue. We also recommended that the Kentucky Board of Medical Licensure and the Kentucky Board of Nursing encourage all primary care providers for children to complete the IPV screening, and then make sure they're completed safely and documented in their social history record. So again, medical providers on the panel have often noted that they don't see any indication of IPV screenings in the child's history. This could be a clear indicator, let the medical provider know these kids are at risk, and to wrap services around those families. Next is another recommendation we have made for many, many years. Family Recovery Court, used to be Family Drug Court. We know there's budgetary issues around this, but as you can see, when you're talking about the two main systems that interface with these kids, it's DCBS and it's the court system. So last year, over half of our cases had prior court history. This is prior to that fatal, near fatal event that brought it to our attention. So we look at this from a prevention lens, and this is where these two systems can really intervene and help these families. So, and again, I think we've made that recommendation 5-6 years. So when we look at cases with prior court history, these are our main risk factors: DCBS history, financial issues, mental health, domestic violence, criminal history, and substance abuse. You will see they occur at a much higher rate with those that are involved in the court systems. Now we're turning back to Joel.
So we're going to talk some now about DCBS issues. So let me preface this first by saying, one, this is not an agency bashing session. We find issues, and we don't have a chart for every one of them, but we find issues with law enforcement, with medical providers, with medical examiner's office. So we really try to do a broad systemic analysis. DCBS sees all these kids though, so they're kind of in the limelight. You know, anytime there's prior involvement in the courts, DCBS is going to be there. So they get more attention just because of their role. The other thing I should say is, I mentioned I retired from them. I am really keenly aware of how hard of a job that is and how beleaguered that agency has been essentially since 2008. So I say that within the context that, you know, sometimes feel guilty because I still like DCBS. I didn't work there for 27 years because I didn't like them. And so I feel guilty about it, but I still feel like as a panel, if there's prior involvement by the agency, and prior involvement does not automatically equate to an error, but we have to give it a close look. So that's what we do, and that's kind of what this is. I have these broken down, at least in my mind, in kind of two primary areas. The first area is what I call a quality service, quality standard type thing. And those are those things like, what's your contact in the family? Were there gaps in your contact? By policy, you're supposed to see the family at least every 30 days. Lack of thorough investigation, untimely initiation, inadequate documentation. All of those things in my mind are closely tied to staffing issues. So if you have double caseloads, you have vacant workers, these things are things that most of these things are what you're gonna see that fall or decline first. I say that all to say that within the last 3 years, I think, the legislator and the administration has done all kinds of really good work, and DCBS, to address the staff turnover issue, and I think things are looking up. The data that we see, that we're looking at today, that this comes from, is from fiscal year 22, which means it's from 2021 to 2022. So all the things that the legislator's done and the administration done has really not had time to take effect. So we are really hopeful that we're going to see things getting better once they get the staff on board and get them trained. But this is kind of what we're seeing now. And it can be disheartening to read these things. And I think the commissioner and the leadership feels the same way. So when we look at these things, obviously the most common thing is gaps in contacts. They're all kind of self-explanatory, I think. I also should say that we being the panel staff, have made an intentional effort to cite good work when we see it and put it in writing and make it specific and give it to DCBS staff so this already beleaguered staff isn't hearing only negative things from the panel or in the press or whatever. So then the other issue here that is not as much or more a systemic issue is the issue of screened out reports. So what a screened out report is, you call DCBS, you say, I'm concerned about this family. They will tell you yes or no, it meets the policy and or statutory definition, and we will or will not accept it. So the couple things about that. We looked at the screened out reports using criminal history, mental health, domestic violence, and substance abuse risk factors, which are among the top ones we see in terms of those kind of risk factors. And we compared the orange line being all panel cases and the blue line being panel cases which there was a history of screened out reports. And interestingly, those issues are all higher in the screened out report. The message being that because someone calls in a report and it's not accepted doesn't mean this family doesn't have needs. So DCBS is doing an interesting project. It's called Community Response, and what they're doing is in about 5 counties, I think, they're setting up a system where those screened out reports are sent to a community partner for them to go out and offer the family services. That's a hopeful response because hopefully the data shows it works and they can expand it. But that way someone is serving those families. But in addition to that, there are those percentages of reports that we feel, the panel feels, that should have met criteria, that the risk was high enough, and that's kind of what we're going to talk a little bit more now. Did I jump ahead? Yes, let me go back. So, one thing that we've seen, interestingly, is we've made this recommendation. The only thing we've recommended to be addressed longer than courts and plan of safe care is this issue. So as would happen in the last several months, this issue has taken on a life of its own. There's been legislative hearings about it, judges have become involved, so we really think like there's going to be some progress. I don't know why I'm so thirsty today, because I'm talking too much. So what we see in terms of our recommendations is that we want DCBS to develop a system where they can weigh factors such as professional reporting source, the age of victim, charge, CPS involvement. Those are kind of like the big three as factors that should make a report, if it's questionable, cross the line and be accepted. So that's one of our recommendations. We want them to expand their data collection process. So what they can do is look at reports were screened out and then track those. And if there was a new report received and accepted within 30 days, start looking as a quality measure, you know, what was led that decision? Was it the right decision the first time? We want them to revise policy to ensure that reports received after hours, we see those at the panel sometimes as well, that don't receive supervisory review until after the evening or after the weekend. So then there's a late initiation on these investigations. One of the issues we've also noted related to the screening criteria is that the panel doesn't necessarily agree, and I think that DCBS staff would agree with this, there's cases in which reports met the statutory definition of a fatality and a near fatality, but weren't accepted as such. And then we find out about those cases, we being the panel, when they come in from the public health response. So our concern is that if it gets screened out at that level as a near fatality, then the panel's not saying it. So we want the system safety staff, that's the staff in DCBS that will examine internally these fatalities and near fatalities, to be involved in that decision whether or not those are accepted or not.
Yeah, I was gonna say, and the designation, because sometimes it can be accepted but not designated as a fatal or
Yes.
near fatal. So therefore, it would not get sent back up to the system safety staff for review. So we're saying to ensure they see them, all near fatal or fatal or referrals get screened by that staff.
Yeah, and I meant to say too, the issue of screening, it really is pretty complex in terms of figuring out how you can weight the reporting source and things like that. But on the panel, we have doctors saying to us, and judges saying to us, I call and I can't convince them to take it. So we feel like there's certain people that you should just listen to them. And so that's kind of what we want to
I think it's
happen.
important to note with the structured decision-making that CPS uses now, we think the age of the victim and the reporting source and the prior involvement is considered, but it's not weighted. So if a
Yes.
professional recalls it in, it's noted that it's a professional referral, but it does not receive a higher level of review. So that's what we mean by weighted consideration for those types of referrals.
So, and again, this isn't intentional malfeasance by anyone. I think there's probably a couple things going on. One of our thoughts is that there's a culture that my role as a central intake worker is to reduce the volume that's coming in. And the commissioner, we had this conversation with the commissioner, she said her perception is that these people are getting hundreds of calls a day and they don't have time to ask the follow-up questions and do the digging in. Both of us could be right, but I think that's why I say this is a complex issue, but
And the system's fairly new. The
Yeah.
SDMB or SDB.
yeah,
tool is fairly
SDM is new. So
Yeah.
we're hopeful that given the new involvement of the judiciary and the legislator, that we're going to see some changes here. Ashley.
So I don't know if this would be the right time to ask this, but when we look at our report, we have the screen in cases, screen out conditions, substantiated and unsubstantiated. I did not.
Unsubstantiated, yeah.
Can you explain the difference of those shortly between?
Yes, it's going to be screened in or screened out. If it's screened out, for the most part, DCBS is done. They won't do anything with the family unless it goes to that community response team or something.
That's where you're talking about the weighting of how they determine that.
So if
Yes.
it's screened in, they'll investigate.
A better policy or process for screening.
Exactly. exactly. And the substantiated, and you won't get to the substantiated or unsubstantiated unless it's accepted for investigation.
And then the substantiated, is that by a medical professional?
No, that's a
No.
DCBS decision.
Only, okay.
Yeah.
And it's based on preponderance of evidence, and there's some variation, I'm probably getting too much details, but they won't substantiate it unless they think they have enough evidence to go to court and prove it, or a family can also appeal the decision through an administrative hearing. So if they don't feel like there's enough evidence, they're not going to substantiate it.
Well, how does law enforcement impact whether or not a case is accepted?
It doesn't affect whether it's accepted. It will affect or can affect, I think, the substantiation, because they have a lot, they're better at investigations. And I mean that nicely. You know, a social work assessment should be a social work assessment, not a determination of a crime was committed. You have law enforcement in there, it really strengthens, especially if law enforcement presses charges, it really strengthens the evidence and it strengthens the worker's confidence. But it won't impact, unless the officer calls and says, I just arrested this guy for DUI, he blew a .9 and his baby was in the back seat. That's going to make it accepted, but.
Yeah, I think it's important to understand that each entity involved has their own role. So just because criminal charges are not brought by law enforcement does not mean that DCBS can't substantiate. Just because an autopsy report says the death was undetermined, still does not mean DCBS can't substantiate on their own findings.
And right, and just to be correct, there's different reporting systems. Are they talking to each other now? Law
What
enforcement,
reporting?
something's called in, or DCBS is called in for.
The statute reads that a person has a mandatory duty to call DCBS, law enforcement, or the county attorney. So either one of those creates the same report. Does that answer your question? Okay. Just to add one more thing to this, we asked them to explore a specialized branch or team to focus on reports made by professionals. Now, administratively, how they figured that would be really hard to do. What we tried to do is the panel and staff met with DCBS and talked through these recommendations, because we didn't want to say, tell me if I get it wrong, we didn't want to say, you will do this, because we don't know their system like they do. So we tried to make it so here's some ideas, talk to us about these.
Yeah, and I think that was one of the outcomes of Senate Bill 97. If we're making these recommendations, that's our opportunity to really talk to these other entities and find out what are your barriers, how can we make better recommendations, let us explain what we're trying to make happen, and let's work together to implement whatever the prevention piece is. So next we're going to talk about firearms, which we saw this earlier. You can see we have seen a substantial increase in firearms. In total, the panel has reviewed 72 firearm incidents in the last 5 years, 48 deaths and 24 near fatalities. Children involved in the near fatal events are often left with just lifelong devastating injuries. In this report, we have including data from other sources, so vital statistics, ED visits, hospital admissions, and again, as we've said, the cases we see are a small subset of the overall number that's happening across the state.
So if I can just
Go ahead.
throw something in. In reading these cases, one of the things that strikes me, these are really heartbreaking cases. They're all heartbreaking, but some are more heartbreaking, but these are terrible, because when you read the investigations, you hear parents say two things. And one is that, well, I didn't know my child knew where the gun was. The research tells us about 75% of kids know where the gun is.
Yeah, not just that they
where it
know,
is.
but they talk to them about safety with guns.
Yeah,
And, they were like, well, my kid knew better. No, research shows otherwise.
yeah, and so it's hard. I mean, you hear these parents, you see their pain and you think, why didn't someone tell them this?
Yeah.
Why didn't they know this?
So last year, we reviewed a total of 18 firearm-related injuries. 11 of these were fatalities and 7 were near fatalities. 11 of the firearm injuries were accidental or unintentional. 4 were child suicides, 3 were homicides. Now, on our homicides, all of these were documented as murder-suicides. So the caregiver, awful, tragic cases. Young children are more likely to be involved with these type of cases. The average age of the victim is 10. Unsafe storage practice were noted in 83% of our cases. And then child access prevention laws has been our continuous recommendation for past 2 to 3 years, as we've noted this increase. So child access prevention laws create penalties for an adult who fails to properly store a firearm in a manner that's easily accessible to children. The majority of states that have enacted some variation of CAP or safe storage legislation, research shows that it has been a great prevention strategies in those states. Anything else to add on that, Joel? No. And I know there's several bills filed this session, but I feel like they're filed every session, so we'll just have to see what happens. And I don't know, do you want to talk about, so the Child Home Safety Committee, when it was first started, we focused on not just overdose prevention, but also firearm prevention. So, you know, when you talk about grant writing, maybe we could find some money for firearm, locks and safety sources, so.
So do you think when we talk about firearms and things, should more of the education be with the kids or with the parents or both?
Probably both, but there's not a whole lot of research that says the education of kids works.
Yeah.
It's not going to hurt, obviously, but I think some of the programs like the Something Eagle guy, Johnny Eagle.
Eddie the Eagle.
Eddie Eagle. I'm sorry, Eddie Eagle. From what I've read, that there's not a whole lot of evidence of efficacy, but you also have to realize that there's not a whole lot of research on this in general because there's a federal prohibition about researching gun violence.
Now, we did have a partner who passed away. I apologize, his name and what they did. He worked in the west part of the world.
Yes.
Firearms, just basically, if you see it, put it down, run and tell adult.
Yes.
He was doing a lot of great work within his community. They were still, I think it may have been a little part of the Eddie the Eagle, but they're still working to try to get someone to take over the program and do that.
Yeah. And that's not to say that we shouldn't be talking to our kids about that, because another thing you see in these cases is people typically lock them up and it only takes one time to forget. One case, it fell out of the guy's pocket and the kid found it. So,
Or leave them in their vehicles.
yeah.
We've seen a lot of those cases.
Yeah, I was just basing that on where you said that 75% of kids knew where the guns were.
Mm-hmm.
So
Yeah.
it's like, there's a high number there
Yeah.
that knows
Yeah.
where the guns are, so it's like, do they know what to do if they come in contact
Yeah.
with the gun, or if they go to where it is?
So, I mean, they've done studies where they tell kids, talk to them about guns, don't touch the gun. Obviously, it's not a real gun. Leave the room, and half the kids will go and touch the gun. Because it's fascinating. What kid's not going to touch a gun?
And we've seen cases where there's also friends are coming over.
Yes.
And they're doing social media posts with guns and accidents happen. We had one case where the kids were playing cops and robbers and with a real weapon.
Yeah.
So,
There's I don't want to get too far here, but there's a proliferation of guns in our culture that I think that's contributed to this as well. Yes.
Well, the other problem that I've seen is, and I've got a couple of teenagers at home too, is that these
God
kids
bless
play
you.
with pellet guns, the
That
pellet
look
guns
real.
look like 45 calibers or 38 calibers, and they're out there shooting in the backyard and pretend targets and all that. So we're actually giving them toys. I mean, I'm 76, so I grew up with caps, cap gun, but we're encouraging that, plus the social media stuff. I mean, they're out there pretending to shoot people now on social media games, and, once they're dead, they come alive again. And you try to explain to the kids, that isn't the way it is in real life.
Yep.
Hey, Steve, at a previous meeting, you had mentioned that you had lock boxes available. Is that still something that you're offering?
Joe's gonna do a presentation on, an update on the medication lock boxes, so we'll have that over.
But
I can get you cable lock many as you want, as well, anybody in the room who need my information after, I can forward it to our national office.
Wow.
Kelly Markham.
I know a number
We're
of
gonna
the
need your
state
information.
kid programs, local elections, and there's 4 or 5 of them here in the state. They have accessed and have been distributing some of those kind of things through their Safe Kid program networks. It would be good stuff to get out to them.
Yeah. Thank you. I'll be calling you. Okay, child suicides, I don't really know why. I review a lot of cases. These are the hardest to review, and I don't know that I can tell you why, but they're just terrible. The panel reviewed 7 cases. The big message is here is I think we got this from DPH. This is the number of suicides over the last 5 years. We had 7, and there's been 29. So 7 of them came to us because there's an allegation of abuse or neglect around it. But there's been 29 of them. So we really are talking about a small percentage of a tragically high number. Of the suicides, 5 involved were fatalities, 2 were near fatality. The number of suicides is obviously a fraction of what we see statewide. In looking at the characteristics, the overriding or the risk factors, the overriding factor we see is what we call unsafe storage or unsafe access. I think Beck calls it lethal weapons or lethality, but it's the same type of concept, and we've talked to this about the guns a lot, but it's also true for medication in terms of suicides, locking up or securing medication. And so again, we've talked about this, but it's imperative that parents have information about the risk of suicide, caregivers, and storing weapons and medication if your kids have risk factors. We don't see it on 7 cases. We don't see a lot of them, but I'm surprised by the number of cases that we see that involve children that are trans or LGBTQ, which is kind of consistent with the research you hear on that is anyways. And I think that's it for that in terms of, except for the recommendation. So what we've recommended for several years is that Behavioral Health Department develop a budget proposal or some process to implement statewide utilization of a psychological autopsy process. And what that is, I think it happens for adults and for children. But for our cases, what we're looking at is it involves a study or review of the case that's more in depth than what we do. The parents are involved. They're trained professionals that do it, trained by the American Association of Suicidology. It engages family members, community members who are involved in the family, and really does a deep dive into what are the circumstances around this death. As much information as the panel gets, there's so many times when I read these cases or a panel member will ask me a question and I'm like, I just don't know. And so I think that's what we're hoping, if this process is implemented, that we can really learn more to help drive our prevention efforts.
I would say when you look at like a normal autopsy, that's looking at the medical cause of death. A psychological autopsy is going to do a much deeper dive. It would send a professional to the school setting to talk to those kids and find out what was going on, maybe a day before, a week before, was there a triggering event? And a lot of this information is what's missing to help us really drive further prevention messaging.
So.
You might want to mention the child home safety.
Oh, yeah, well, this is our contact information. That's the information for the Child Home Safety Committee to
The lock boxes.
look at lock boxes and things, other resources like that. Hold that thought. At lunchtime, I'll be giving a background or an update on where we're at with those right now. So is there any questions? Thank you for your patience with a dark topic. I have a question for you. There's no questions. Okay. Did you hear? Oh, Van.
You know about requiring KBML or someone to promulgate regs when MOUD is prescribed? That there be some education about lock boxes.
Did we miss that?
That's what
Yes.
our recommendation this year was to them
Okay, you say
for
that.
that. Yeah.
Yeah.
Yeah. So we were asking that there be, I think right now they're required 4 hours training. We asked that at least 1 hour of that be dedicated to safe storage, safe sleep, and risk factors. And I think right now they have maybe one training, the continuing education training that's on their website. But we think they could do more. And right now it's not required. So they get to choose what 4 hours of training they want.
Okay, if there's no other questions, I have a question for you. Did you hear about the king that was 12 inches tall? He was a terrible king, but a great ruler. My grandson loves telling me that joke over and over again. Thank you.
Thank you, Joe. Thank you, Alicia.